Hello, ladies and gentlemen. Welcome to the Docs RN. We have an exciting episode for you today, and a topic that'll touch many. So I'm an epileptologist at the Cleveland Clinic, Abu Dhabi, and I have the pleasure today of speaking with Dr. Maria Rabbani, who joined us approximately a year ago, graduated from the Mayo Clinic, and has special interest in the topic of women with epilepsy. So that's what we'll be talking about today, and we'll go through a broad range of topics with respect to this. So first of all, I'll start by mentioning, Maria, that women need specialized treatment in epilepsy apart from other patients in general, and that there's a reason for that. Hormones play a major role in seizures and play a major role in breakthrough seizures. So if you could walk me a little bit through how do hormones play a role with seizures and medications for seizures?
Thank you, Dr. Eugene, for the kind introduction. So, this is a very broad topic, and to start off with hormones and epilepsy. Hormones, they work in such a way that it affects or they fluctuate throughout the menstrual cycle, and with that fluctuation, it can affect the seizure activity. So, especially with women with epilepsy, the fluctuation in hormones there are certain periods where the seizures may be more prominent than the other times. So there are mainly two hormones that are at play. One is estrogen, which is excitatory, which means that there is more risk for seizures if the hormone level if estrogen levels are higher. The other hormone is progesterone, which has exactly the opposite effect. When that is higher, that means that it has an anticonvulsant property. It's inhibitory. That means that there's less risk of seizures. So throughout the menstrual cycle, there are periods where that estrogen and progesterone ratio is high. For example, during ovulation or around the time of periods. So we usually get complaints that around these times, patients may feel that they're more vulnerable or their seizure clusters more around this time.
That's great. We've seen estrogen play out in other conditions as well. For instance, with catamenial migraines, the migraines tend to get worse also before or during the period or mid-cycle, and that is also due to the increase in estrogen. It is an excitatory, or estradiol is the other name for it. So that's great. So how do we mitigate the risk of having a breakthrough seizure? Because as you know, breakthrough seizures are awful. You can go from being able to drive to suddenly having to wait another 6 months, and that's important for independence. So what do you do to help a woman manage this?
So like you said, we see this very frequently in clinics that, like you mentioned, catamenial migraine. We have catamenial epilepsy where during certain periods, the seizures are more common in the menstrual cycle. So the most common one is around the time of periods, say 2 days before to say 3 days into periods, where patients mention that they clearly notice their seizures are either purely happen at that time, or there's an increased frequency. So there are a few strategies that we can utilize. One is that we could potentially increase the dose of the anti-seizure medication temporarily, just during that period, or we could add another anti-seizure medication just to cover that vulnerable period. The other thing that we could do, like I was mentioning earlier, progesterone, it has an inhibitory effect. So there are progesterone lozenges that can be given during specific periods. Now, there are some patients who have irregular periods, so we can't really predict when they're going to get period. And so we could use oral contraceptive medication to sort of maintain a steady hormone state. So that is another option that we usually utilize.
That's great. And some of these short-acting medications can be easily gotten on and off
Absolutely.
of. So the patient does not feel that they're, oh my God, I have another medication to take.
Yeah.
So that's reassuring. Another strategy I have used is acetazolamide, which is unusual. We don't understand the pathophysiology, but also during that time can reduce seizures by approximately 60 to 70%. That's great. So we're going to stick to the topic of contraceptives for a second. Sometimes patients are started on these medications and they present with a breakthrough seizure. But sometimes they're necessary. Say they want to prevent pregnancy, or they have PCOS or other conditions that require their use. How do you mitigate that, and how do you instruct them on which medication to take in order to prevent pregnancy or for any other reason without worsening their seizures?
Yeah, that's a very important question, because we want to make sure patients understand that there is an interaction with some medications and oral contraceptive pills. So one is, I try to counsel any woman in the reproductive age group that, they have a discussion with me when they do try to conceive. So we have a plan laid out for the future in terms of seizure control and the right medications to use. Now, if a patient wants to go on oral contraceptives, we keep a few things in mind. There are some medications that can potentially increase the clearance of oral contraceptives. For example, there are some enzyme inducers like carbamazepine, phenytoin, phenobarbital. These medications, what they do is they increase the clearance of oral contraceptives by increasing the liver enzyme activity. So what that does is that the hormone level decreases, and with that, it can result in unplanned pregnancy. So a big part of it is counseling and discussion with regards to which medication to decide for anti-epileptics. Now, there are other strategies that can be utilized in terms of contraception. It's not just oral contraceptive pills. There are some other contraceptive options that do not interact with any anti-seizure medication. For example, intrauterine devices, whether they are hormonal or non-hormonal. Apart from that, there are depot progesterone injections that are safe to use with anti-seizure medications.
Great, wonderful. Okay, so let's say a woman is planning to get pregnant. There's a stigma associated with having epilepsy and planning pregnancy, and oftentimes I've had patients tell me, tearful and saying, I don't think I can get pregnant, or I can't get pregnant. So it strikes me how much this affects the patient. Even though most patients who do get pregnant, over 80%, do very well. So how do you approach this topic? How do you reassure your patients? Walk me a little bit through this nuanced conversation that you may have.
Yeah, that's a very important question, because a lot of times patients, pregnancy in general, it is for any woman, it is a life-changing event. And on top of it, if someone has epilepsy, it is associated with stigma. So a big part is reassurance and walking through even before they get pregnant. So preconceptional counseling is absolutely critical, wherein we discuss, first try to alleviate fears before we get into medications and what happens and whatnot. So it is very reassuring that the studies have shown that compared to women who do not have epilepsy and women who have epilepsy, the chance of getting pregnant is the same. So epilepsy in itself does not affect your chance of getting pregnant. So that's the first thing. The second thing is that it is possible certain medications may indirectly affect fertility. For example, there are some medications, say valproate, that can cause irregular cycles or polycystic ovarian syndrome. So those factors are something that we want to consider. But overall, it is reassuring that patients do get pregnant, and more than 90% of pregnancies are fruitful, like there's healthy mother and healthy baby. So that is reassuring.
Yes, absolutely. And so once you do get them over their fear, and looking at their history and the medications they're on, what are the next steps that you try to take over the few months before to help them through this?
Yes. So before what we ideally aim for is 6 to 12 months, ideally 12 months of well-controlled seizures, best if they are seizure-free, a year prior to pregnancy. Now, when they come to us, there are a few things, there are a few checklists in my mind. One is, what medication is the patient on? Is this medication safe for pregnancy? If it's safe for pregnancy, then I go through, is this the lowest effective dose? That means, is this the lowest dose at which the patient's seizures are well controlled? And if this medication doesn't fall in the safe category, that means that there is some risk of teratogenicity. Then we try and switch to other medication that is more safe. Second, and this is patients with in reproductive age group in general, we want to start them on folic acid. So we do that when there's preconceptional counseling. Lastly, I try to obtain drug levels before they get pregnant so that I have a baseline at which that would be a data point. So during pregnancy, if we were to make changes to the drug, I know what is the effective level for that patient. So that helps in alleviating a lot of fears and unknowns associated.
And that is a really important point, because at least my patients here are always worried about how many milligrams am I taking? Oh gosh, doc, don't make it any higher. So I try to set expectations beforehand, and I explain to them that we will, in all likelihood, raise your medication during pregnancy. And so what are the reasons why we need to raise the medications during the pregnancy?
A big part of it is pregnancy is the whole body changes during pregnancy. There's increase in the volume. The metabolism of the drugs of drugs increase. That means, say a patient is taking lamotrigine, it is cleared like 50 to 60% higher than a pre-pregnant state, and that increases as the metabolism or the clearance increases as the pregnancy progresses. So essentially, you're giving the same amount of, or the same amount of medication is left in the body. It's just that you have to give a higher dose to reach the level that you were giving before. So setting expectations, like you said, is absolutely important. So they're aware of what they're going to go through during pregnancy, essentially.
Absolutely. And I try to reassure them by objectively explaining, we're going to check your level every couple of months, every 6 to 8 weeks, and make sure that it stays the same so you don't get any toxicity. And there are many reasons for that, as you mentioned. I mean, the estrogen rising, there's a bidirectional relationship with also estradiol lowering some of these medicines, the volume of distribution, the expansion of the volume of distribution. So one of the things I also get is a fear of, okay, hiring medicines, which is worse for my baby, or having breakthrough seizures. Yeah. And that's always another conversation I have to have, that one is riskier, one is less risky. What are the risks of having breakthrough seizures, whether generalized or focal, and affecting the child, the fetus?
Yes, so it like you mentioned, we get this all the time. Patients are very concerned about development of the baby, or should I just stop the medication because it's going to harm my baby? It's important to know that the risks associated with a patient having seizures are far greater than the risk associated with taking the anti-seizure medications. Now, say a patient is having a convulsive seizure. What can happen is, apart from the mother, who could potentially face injuries or falls or fractures, to the baby, there can be decreased oxygen supply, and that can negatively impact the development. So it is important to understand that seizure medications, if selected correctly, they have a lower chance of affecting the mother and the baby than stopping the medication or decreasing the dose without consulting the physician.
Absolutely. That's very important to stress. And at the same time, we have to reassure them that should they have a breakthrough seizure, it's not very likely from one breakthrough seizure to cause an anoxic brain injury. But tell me, does a focal seizure affect the baby as much as a generalized seizure would, theoretically?
Theoretically, no. A generalized seizure would sort of have more impact compared to a focal seizure, but overall what we want to do is we don't want recurrent seizures. If it is reassuring that studies have shown that in general the seizure control in pregnant patients with epilepsy versus non-pregnant patients with epilepsy is similar. It's just the dose changes are more frequent. So theoretically there is less risk compared to generalized seizure. However, we don't want patients to have recurrent breakthrough seizures.
Absolutely, because that can be a heralding sign of a larger seizure oncoming. So definitely, especially using our secure messaging system, I insist on the patients to let me know, even if you have a very small seizure, send me a message so we can adjust the medications. Very good. So speaking of seizures, another thing that the seizures can do is increase the stress hormone, and that can increase the stress on the woman's body and can lead to a premature delivery. So that's another concern that we ought to have, and we should tell the patient as well. So let's say, by the grace of God and the good leadership of the physician, the patient gets through the pregnancy and does well. Now we have to talk about what happens immediately after delivery, and a lot does happen immediately after delivery. Can you walk me through some of the changes that occur in the body and some of the steps that you take to mitigate any risks of toxicity, but at the same time keep the mother healthy and safe in this stressful period?
Absolutely. So after pregnancy, and during pregnancy itself, we try to set expectations that in the postpartum period that we will be decreasing the dose of medication, because the body is going to go back to the pre-pregnant state, although more gradually. The volume will decrease, the metabolism of the drugs will go back to the pre-pregnant state. However, we need to consider that postpartum period is critical for the mother, because there are other factors that can trigger seizures, like sleep deprivation, which is a big one, stress associated with the arrival of a newborn. So keeping that in mind, we do gradually decrease the anti-seizure medication, but we do not immediately bring it back to the pre-pregnant state because of the factors that I mentioned earlier, so that we have some additional buffer going through in the postpartum period.
Absolutely. And this is a time where you might tell the mother, nap with your baby. Take it whenever you get a chance. Absolutely.
Easier said than done.
Yes, absolutely. So it's safe to say, essentially, that it's a balancing act after delivery between avoiding toxicity, because suddenly estrogen drops and some of these levels may go up for their medications, but at the same time, keeping in mind lifestyle, lack of sleep, stress, many triggers that we typically assign to having a breakthrough seizure. And how much do you drop the medications typically? I typically go somewhere between the second and fifth day, about 25%, and then gradually every week. Do you have a particular mechanism that you follow?
So I usually let the patients know, like you said, around 30%, 20 to 30% on the second, not really the first day, but second day, like you mentioned, and then gradually check levels maybe after 2 weeks of delivery.
Yes,
and then
levels are critical
correct.
at this point. And try to compare them to pre-pregnancy levels, which you reminded us to do at the beginning. Another reminder is it's really essential to take folate during the pregnancy, and that comes from data with neural tube defects, particularly with the older anti-epileptics. How much folate do you tend to use, and when do you start it typically?
So folate, I generally tend to start any patient in reproductive age group. I usually start around 1 milligram, and if say patient is on on one of the older medications, then I try to use between 2 to 3 milligrams. But the main point is that it's important that patients take folate, whether they're planning to conceive or not planning to conceive, because we know 50% of pregnancies in general are unplanned. So like you mentioned, the studies, the NEAT study that looked into effect of folate on development on patients taking some of the older anti-epileptic drugs have clearly shown improvement in better development and cognitive profile in mothers who took folic acid versus those who did not.
Absolutely. And you mentioned something strikingly important here, because we see this all the time. Pregnancies are often unplanned. So that conversation needs to be had with a patient in any reproductive age routinely and periodically. Hey, are you planning pregnancy? Are you planning pregnancy? Because some of these medication shifts that we may need to go through may take a long time.
Yes, in fact, even if a patient is unmarried, I ask them, "Are you planning to get pregnant? The moment you get married, just let me know so we can work on what needs to be done in case you do plan to get pregnant." So this is a conversation I have literally on the first visit when I see patients within the reproductive age group.
Very good. And it's really important to stress, when you're planning pregnancy, you ought to let us know versus when you're pregnant, right? Because most of the time, by the time they found out they're pregnant, a lot of the potential damage has been done to the central nervous system in development. Very good. So let's move on here and say everything went well, and now mom is considering breastfeeding and has some questions about breastfeeding. Am I on too much medication? Is it going to affect my baby? Will it make him sleepy, etc.? How do you deal with this question?
So we get these questions all the time, that should I just formula feed my baby because the breast milk may have the medication and it's going to affect the baby's development or the baby's brain development or cognition. The short answer is it is recommended to continue breastfeeding the baby, because we know that the benefits of breastfeeding is far more, like whether it's nutrition for the baby, mother-baby bonding, immunity development of the baby, and the small risks that are associated with anti-seizure medication intake. So there's a small amount of medication that is secreted through the breast milk, but that is very small to cause any significant damage. Now, there are some older medications, like, for example, phenobarbital, that are secreted in a higher amount. What we recommend in general is to continue feeding the baby and watch for signs, like you mentioned. Is the baby very sleepy? Is he or she not latching properly, or there's some failure to thrive? So this can be an ongoing conversation with the doctor, but in general, it is safe. In fact, it's recommended to continue feeding the baby.
That's great to know, yes. And another thing I use sometimes is looking up the relative infant dose for each medication and reassuring the patient that if the relative infant dose is less than 10%, it's generally safe. And this is what we know about this medication based on how a few studies done on each. That's wonderful. Okay, let's shift gears now and speak generally about epilepsy in a woman's life. What are some lifestyle tips that you have for young women or older women with epilepsy?
In general, for all patients with epilepsy, there are a few things we almost in every visit really discuss about is sleep deprivation. We want to make sure that patients are sleeping well, 7 to 8 hours, ideally of uninterrupted sleep, because we see it all the time in the clinic that I was driving, I was out all night, I was flying, and I didn't get enough sleep, so that's how I ended up getting the seizure. So that's number one. Second is with regards to
just for a second, mentioning sleep is so important. I mean, we have an epilepsy monitoring unit here, and the goal of admitting patients to that place is to trigger seizures. And what do we use to trigger seizures? Inevitably, sleep deprivation. We force our patients to sleep for 4 hours, and almost always they end up having seizures within 1 to 2 days of missed sleep. So it's so important. And I don't have seizures, but if I get less than my 7.5 hours of sleep, the next day I'm rowdy, irritable, can't focus. So I can only imagine there are many factors for this, not just sleep raising the risk of having seizures, but also it causes more stress on the brain, on the body. This is the recovery time for the brain.
Absolutely.
What else should we counsel them?
So the other thing we recommend is moderate exercise, light to moderate exercise. If, say, a patient is pregnant, then we recommend something like walking, prenatal yoga, or stationary cycle. It helps with improved mood, better sleep. The other thing when we talk about sleep is if a patient is really struggling to sleep, we do prescribe melatonin, because what that helps is, it is absolutely crucial that patients sleep. So if we need to give additional medication to help with that, we do that. Apart from that, we also discuss about caffeine. Sometimes patients ask, can I have coffee? Can I have Red Bull or any of
Absolutely.
the...
It's so widely distributed out there, and people don't know that these things last in your system a considerable amount of time. It takes almost 8 hours to get rid of half of the amount that you drank. So I generally tell them after 2 p.m., don't drink any caffeinated beverages. Is this kind of what you
For
counsel?
energy drinks, I think I'm more harsh. I just tell no energy drinks.
Yeah,
For
absolutely.
coffee, I say like 1 to 2 small cups. For example, in pregnant women, we say less than 200 milligram. That's been standard across for any woman with epilepsy, regardless if they have any woman, regardless of whether they have epilepsy or not.
Yeah, those energy drinks are spiked with caffeine. Could be 150, 200 in each drink. Very good. So other advice about lifestyle. When it comes to exercise, a patient may be scared to exercise. What kind of exercise would you choose to avoid if you were having epilepsy?
It also depends on how well controlled the
Exactly,
epilepsy is.
absolutely.
I think that's an important aspect. For example, swimming. If a patient had a breakthrough seizure, we do recommend them to avoid swimming unattended for at least 3 months or till their seizures are well controlled. I also recommend usually to avoid weightlifting above their head in some cases, because I had one patient, who had a seizure while they were lifting weights, and we don't want that. So those are some of the things I try to keep in mind, or like contact sports, for example.
Sports, or I would imagine rock climbing.
Yes.
I'm already scared of that, but imagine having a seizure while you're halfway up there. Very good. Obviously, we would also recommend wearing a helmet if you're biking. But generally speaking, it's common sense. Avoid doing any activity that may put you in danger should you have a seizure. So keeping on with other tips and tricks here, and it's hard to take medications, I have to say. I'm the physician, I prescribe them, but I also have to take a few medications and supplements, and boy, do I find myself missing doses from time to time. So how important is it to take specifically seizure medications on time, and why?
It's absolutely important. I understand it's hard. It's hard to take medications like you mentioned, especially sometimes patients are taking 2 or 3 times a day, which can definitely be hard. However, we need to understand that a lot of these medications last for a certain time period, and if you delay that, there is a risk that you have an open window where there isn't enough medication in the body, and that can result in breakthrough seizures. So every single visit, all of us, we counsel patients on a couple of things: sleep deprivation, stress reduction, and medication compliance.
Absolutely. And I usually use a graph here and explain to the patient how important this is, because we try to shoot for what's called a steady state, which is 2 levels where the medication fluctuates between up and down. And often if you miss one dose, it can take 2 or 3 subsequent doses to get you back to that. So it's very important to take the medication on time. And one thing we do as physicians, if we feel like the patient's having a tough time with compliance, is we could consider a once a day type of
The dosing,
medication
yes.
to improve that compliance.
The other thing I tell patients is stack it like a habit. So keep your medicine, say you have breakfast, make sure you just keep it on the table. So you have your breakfast and you eat it. Or at night, keep it next to the bed or something that would remind you that you need to take your medicine, or best
Yeah.
set an alarm.
Do you use a pill box? I'm a fan of the pill box.
I mean, for younger patients, it doesn't really help. I think
Yeah.
for the older patients, when they have a lot of medications, yes.
I think it's mostly for supplements.
Yeah.
But, that's great. I also have an Apple reminder every day at a specific time, so that can be used, part of the health app. So if you're technology savvy, that could be something helpful. Very good. So one last thing, when it comes to triggers with seizures, a lot of times people have seizures when they're very stressed. And so we try to ask them to use meditation and a holistic type of approach to reduce their stress, maybe take on less tasks, maybe increase their exercise, etc. But there is one more trigger that is frequent. We get people that come in, especially in this country where there's a lot of heat outside and temperatures can range. Dehydration, right?
Absolutely. So we recommend hydration. It's a big part of it, and especially especially important throughout, like for all patients with epilepsy, and especially if, say, for example, a patient is down with the flu, since it's the flu season, then there's the patient's immune response is already low, and if you're not taking enough rest, you're not hydrated enough, that can trigger seizures. So hydration in general is important, but definitely more so if a patient has those sickness periods.
Absolutely. Okay, well, Dr. Maria, thank you for this stimulating and great conversation about women with epilepsy. And I want to thank everyone that tuned in to listen to us, and I hope that you've benefited from this conversation or at least found it interesting. So with that, I will say bye, and until next time,